Good afternoon, everyone. How's everybody doing? Hi, Michelle. Oh, Michael, you're on here. Hey, Liza. Wow, we have Rankin on the line. We have Danielle Rankin on the line. Uh, oh, hey, we have somebody from New York. Yay. All right, everyone. So today we have a guest speaker. As you know, we ended cohort 3 on the 4th. So our regular Friday meetings have now ended, and our plan is to do one guest speaker every month. So our guest speaker for this month is Jillian Hayes. And it's so funny, Rankin, that you're online because she did her residency at Vanderbilt, and you're doing your PhD at Vanderbilt right now. So that's a little connection there. But yeah, she's really, really fantastic. She works here at Advent Health Celebration with me. It's We are so happy to have her here as part of our team. And with this group, we have a lot of people who are, EPIs, we have infection preventionists, and one of the things that I know I really kind of struggled with when preparing for my exam was like learning some of these antibiotics. I did my bachelor's in public health and my master's in public health, and I never had to take a pharmacology class. So for some of these questions, I watched a lot of YouTube videos, and so I wanted to make sure that we had somebody who could come and talk to us a little bit about antibiotics, and that is Jillian. So she is our infectious disease clinical pharmacist at Advent Health Celebration, and we are really, really excited to have her here today. And hey, Debbie, I'm so happy to see that you're on the line. Debbie was the first person who passed her CIC exam in cohort number 2. She's amazing. But we'll go ahead and get started. So without any further ado, I'm going to go ahead and put little Miss Jillian. She's a ball of fun. I'm going to put her on the line. Okay, here you go.
All right. Hello, everyone. I'm super excited to chat with you today about some of my favorite and least favorite drugs. This headset already has me feeling very legit. I feel like Britney Spears with this on, so this is going to be a good hour together. If you guys have questions as we go along, just go ahead and type them in and I will answer them as we go. And without further ado, we can go ahead and get started. So, as Luz mentioned, I'm the infectious diseases clinical pharmacist here at Advent Health Celebration, which means I did undergrad. I was a pre-pharmacy student at that time. I did 4 years of pharmacy school, and then I did 2 years of postgraduate training at Vanderbilt University Medical Center. Let's make sure I still know how to advance a PowerPoint here. There we go. All right. By the end of our hour today, I want you guys to feel more comfortable with recognizing the classes of antibiotics as well as some adverse events, spectrum of activity, all of that good stuff. I was taking a look at some sample questions from the materials that Luz had shared with me, and some of those antibiotic questions are no joke. I think several pharmacists would maybe struggle with some of them, so this is hopefully going to be a good review and at least give you guys some resources that you can refer back to in the future. I will go over a little bit of the job functions of a stewardship pharmacist and how you may interact with my people in the future. And then we will talk a little bit about resistance and discuss the awesome relationship between IP and pharmacy. I do not have any disclosures. Please read that as I am poor and paying off student loans. This presentation, just wanted to go ahead and obviously state that this is not a comprehensive resource, but I hope that it will help you. And I want y'all to do really, really well on your exam. Okay, so jumping in, this is one of my favorite graphics to start with because it kind of shows that in the realm of humanity, we haven't had antibiotics all that long. You can see that the discovery was really closer a little bit before 1930. So the fact that we've had antibiotics for, I guess, almost 90 years now, and we are already losing some of them, just puts into perspective how valuable these medications are, and we'll break these down by classes as we go. Before we get into the individual classes, I want to go over a couple of characteristics that lead us to grouping these drugs into the classes that we group them in. One of those is the mechanism of action, or how the drug kills the bacteria or inhibits growth of the bacteria. Next is spectrum of activity, which means which types of bacteria that drug's able to cover. And then cidal versus static. So these are different degrees of killing is the way that I like to think about it. Cidal drugs actually are able to kill the bacteria on their own, and you require less concentrations of drugs to do so. So you may hear people say that these are better killers, and that'll be important in certain infectious disease states. We'll go through that when relevant for each class. And if something is static, that means that it kind of stops the bleeding, if you will. It will inhibit future growth of the bacteria, but it's going to need a little bit of assistance from the immune system, so from the actual patient, and we also may need more drug. Unfortunately, oftentimes more drug comes with more side effects, and not all patients have intact immune systems. So this can help us make decisions about which antibiotics to use. I want to briefly touch on kinetics and dynamics because I did see that some of the sample questions referred to these principles. This is something that I explain to all trainees that I have with me, including Luce when she came and spent some time with me up on my unit. These are concepts that aren't always gone over in school, so I think they're important because we certainly reference them out in the real world, as I like to say. So there are 3 different parameters that we can optimize with antibiotics. This is essentially describing the way that they best kill bacteria. Those 3 categories are time above the MIC, or minimum inhibitory concentration, Cmax, or the maximum concentration above the MIC, and then AUC, which is area under the curve over MIC. I think that this graphic is what explains it the best. So going with the first category, Cmax over the MIC. Oh, perfect. I'm about to get a laser pointer and everything. This is wonderful. Thank you. So Cmax above the MIC means that this maximum point is the most important thing for the bacteria. This dotted line represents our minimum inhibitory concentration, or MIC. That means that the concentration of drug has to at least clear this amount in order to be effective. We get the MIC on a patient-specific, organism-specific basis in the susceptibility reports from the microbiology lab. So for drugs that best operate with Cmax to MIC, we want what I like to call a tall mountain. We want this maximum point to be high above this dotted line. For drugs that are optimized with AUC to MIC, we want the area under the curve to be optimized. That is this gray shaded area. So we certainly want tall hills, but we could also have wide hills as well to optimize this entire gray area above the MIC. The last category is time above the MIC, which means that we want the concentration of drug to be above this MIC as long as possible. One of the questions that we'll get to in just a bit, one of the practice questions, acknowledges that there are certain killing methods that do not require the concentration of drug to be above the MIC. And that's actually true. If you look at this AUC to MIC, there is gray shading down here. It does not need to be above the MIC the entire time. Only drugs that are time-dependent killers need to be above the MIC most of the time. So it's a tricky concept. It's not one that's very intuitive. And as we go through the classes, hopefully these will begin to make a little bit more sense. This is more a reference for you guys as we move through. There are lots of different charts that help you learn antimicrobial susceptibility. This is one that I pulled off of Google. I like that it breaks it down by gram-positive pathogens over here, gram-negative pathogens over here. It doesn't include every antibiotic on the market, and unfortunately, I do not have many tips and tricks for you in terms of memorizing spectrum other than memorization. It's one of the hardest things. I think I did incredibly poorly actually on all of my ID exams in pharmacy school because this concept is tough. I still refer back to it as an ID pharmacist to keep myself honest and make sure that I understand the spectrum. So having a pocket reference like this, there's no shame in that. I carry one around, but just wanted to make you guys aware that these resources are out there. All right, getting into our first class of drugs, one of my favorite classes, the beta-lactams. These agents are cidal, so they are great killers. They do not require super high concentrations of drug, and they don't require much from the immune system in order to be effective. The PK/PD parameter that we want to optimize with these is time above the MIC. So we don't need tall mountains. We don't need a large area under the curve. We just need the concentration of drug above that minimum concentration for as much of the dosing interval as possible. The way that these drugs actually work is they inhibit cell wall synthesis. So they literally will break down that barrier in the bacteria, and the bacteria are not able to survive. Beta-lactams are somewhat of an umbrella term, and it encompasses our penicillins, cephalosporins, carbapenems, and aztreonam. To review those one by one, penicillin is where this all began. I like to think of this photo as a picture of a young Alexander Fleming who discovered penicillin just by leaving some bacteria out on the table. Arguably the best accident that we've ever had in the history of humanity. Penicillin is available as intravenous, intramuscular, and oral formulations. Unfortunately, because we started using it, it was a double-edged sword in the sense that it started to lose activity somewhat quickly, especially with its widespread use for sexually transmitted diseases in particularly wars where that was rampant. The next class that was developed were aminopenicillins, which include ampicillin and amoxicillin. So I think of amoxicillin, this should actually not say IV, this should just say oral. Ampicillin is both IV and oral, but amoxicillin we know as the oral cousin, if you will, of ampicillin. I'm sure that y'all have a fond memory, or maybe not so fond memory, of taking amoxicillin for strep throat or an ear infection as a child. That's that typical pink liquid that I thought tasted really good as a kid. Maybe that's how I knew I was destined to go into ID. I would walk into the pediatrician and say, I want the pink stuff. Next came anti-staphylococcal penicillins, which actually got their niche in treating staph. These drugs are some of our drugs of choice for methicillin-susceptible Staph aureus. We hear a lot about methicillin-resistant Staph aureus, but I want to give MSSA, or methicillin-susceptible Staph aureus, the credit that it is due. It is still a nasty infection and certainly carries mortality risk. So these drugs offer us a really great arsenal against that pathogen. Some things that we have to monitor are the patient's liver function tests. It can also cause kidney injury, so we will monitor serum creatinine, which is a marker of kidney function. Something specific to nafcillin. Nafcillin and oxacillin are our two IV options, and depending on the hospital's formulary, they will use one or the other. But nafcillin has a very high sodium load, and the way I like to remember that is the first two letters of nafcillin are Na, and that is sodium's abbreviation on the periodic table. The next sort of subset of penicillins that we will review are penicillins plus beta-lactamase inhibitors. We'll talk a little bit later in the presentation about mechanisms of resistance. And one of the ways that we were able to start overcoming beta-lactamase, which is an enzyme that causes resistance, is by adding these inhibitors. So you'll see our friend amoxicillin and ampicillin, we just talked about them. The inhibitors are things like clavulanate, sulbactam, tazobactam, and when you add these, you're able to overcome this beta-lactamase enzyme. A fun story that I love to tell about Unison, you may see Augmentin and Unison used for human bite wounds, sometimes dog bite wounds, as well as fight bites. This is an actual medical term. When I was in residency, I'll never forget this patient. He was not wearing a shirt. He was telling me all of this without his dentures in and only wearing his boxers, talking all about his fight bite. And I said, "Sir, I'm unfamiliar with that term. Could you please explain to me what happened?" He said that him and his neighbor were arguing over a piece of property. This is the most Tennessee story you'll ever hear. And his neighbor started to drive towards him with his international harvester. He had jammed him up against a telephone pole, and he said, "Once I realized my feet were still attached to me, I started swinging, and he gave me a fight bite." So literally human bite wounds. We did put them on Unison. So there, you'll never forget that. I don't know if fight bites will be on your exam, probably not, but they should be, because that's a great little fun fact about Unison. Had a question come in about, can we get a copy of this presentation? Absolutely. This will be made available to you guys after the session today. The next medicine that I want to talk about is Zosyn. So I call this vitamin Z. It is part of the welcome package in so many emergency departments. If a patient comes in with a suspected infection, we will start Vancomycin and Zosyn a lot of the times as our broad spectrum coverage. This covers our two big bugs of concern, MRSA and Pseudomonas. So piperacillin tazobactam's activity against Pseudomonas is really one of its niche areas in therapy. New data, because we use it in combination with vancomycin so often, is that we have to monitor kidney function. So just a little pearl if you hear someone talk about that. Moving from penicillins to cephalosporins, so still under the umbrella term of beta-lactams. Thankfully, they make it easy for you to remember. They will all start with either CEF or CEPH, and that's the name of the class. So whoever designed these knew that this was going to be tested one day, and they were trying to help us out. You'll see that as we move from first generation cephalosporins down the generations, you lose gram-positive activity and gain gram-negative activity. Sorry, I'm going to take a drink of water real quick. The exception is when you get down here to the fifth generation of cephalosporin, which is ceftaroline. Ceftaroline is the only cephalosporin that will cover MRSA, but you lose your pseudomonal coverage. Drugs like cefepime and ceftazidime will cover Pseudomonas. So again, we're gaining gram-negative activity as we go down the generation. The buck stops with the fourth generations, and your fifth generation is unique that it's the only cephalosporin to cover MRSA, but you lose your pseudomonal activity. There are some cephalosporin combinations that are also with beta-lactamase inhibitors. These drugs help us treat some of our most resistant bacteria that we have, so they should be used with extreme caution. These are typically restricted only to ID, and at Vanderbilt specifically, they were restricted to stewardship. So our stewardship attending, not just all of the ID doctors could not order these, it was the stewardship attending specifically that had to approve them. Because they're so powerful, we want to protect them, so we would review those cases very closely to determine whether or not they would be necessary for use. No cephalosporins have activity against Enterococcus. It's a common thing that comes up. And again, these just for resistant bacteria. Carbapenems is the next branch of the beta-lactam antibiotics, and I like to think of these as the Gaston of antibiotics. So these are, I'm not sure where in ID we picked up gun terminology, but you will hear people say these are big gun antimicrobials, and I suppose that is true. I like the Gaston of antibiotics. I think that is a little gentler of a metaphor. These all end in penem. The class name is called the Carbapenems. Again, people were helping us out when they started to name these. Ertapenem and meropenem are probably the two that you will see most commonly in practice. Ertapenem is a little bit more narrow. It lacks ape activity, so it lacks Acinetobacter, Pseudomonas, and Enterococcus activity. That's what the A, the P, and the E stand for. So a way that we learned a memory trick of that was ertapenem was monkeycillin and meropenem was gorillacillin. I'm not sure where we came up with that. We were probably tired, but ertapenem a little bit more narrow. Doripenem in certain studies had higher mortality rates, so you really should never see doripenem. Meropenem is sort of the carbapenem of choice if you want to cover Pseudomonas. And then imipenem actually has the highest rate of seizures. So that one is more so reserved for nocardia, some infections where it has some unique activity. Because the ADE that is most common, or adverse drug event that's most common, is seizures, we have to be really cautious in patients with a history of epilepsy. And then the most important drug interaction to remember with these is we don't use them with valproic acid because that can actually induce a seizure. Valproic acid, Luz had a great question. What is valproic acid? So that is actually a seizure medicine, but it can also be used for bipolar disorder and some other mental wellness disorders as well. Good question. I got another question about, will these slides be available? Absolutely. You guys will get them after the presentation today. Aztreonam has great question. Just got another one. Just imipenem as an ADE of seizures. Seizures apply to everything. All of the carbapenems have the possibility of inducing seizures by lowering the seizure threshold. Imipenem just has the highest rate. That was kind of the one that it was associated with first, but certainly possible with any of them. And then which one was the gorillacillin? Meropenem is sort of referred to as the gorillacillin because it covers the Acinetobacter, Pseudomonas, and Enterococcus that ertapenem lacks. I think the only two that we have on formulary here are meropenem and ertapenem, and then we were able to procure imipenem if we needed it for nocardia or a specific infection. Great questions. All right, Aztreonam is a cidal drug and rounds us out in the Betalactam tree of drugs. It has gram-negative activity only. Because of resistance, Aztreonam is not used a ton in practice. You may see it. It has an inhaled formulation, which is a unique dosage form that is of help in our cystic fibrosis patients who are typically colonized with Pseudomonas. So the inhaled formulation you may see, and we will briefly touch on maybe finding a niche in combination with Bactrim, one of those beta-lactamase inhibitors, for the treatment of multi-drug resistant infections. All right, end of beta-lactams. Any other questions before we move on? All right, if y'all don't have questions, I have questions for you. So just to get you started thinking in an exam format, which of the following is true about cephalosporins? As you move from first to fourth, you gain gram-positive activity and lose gram-negative. Cefepime is a third-generation cephalosporin. Cephalosporins are a drug of choice for infections caused by Enterococcus, or ceftaroline is the only cephalosporin with MRSA coverage. All right, you guys are so wonderful for participating via the question. Okay, I've got D's, B's, actually all four letters represented, so this is good. Moment of clarification. I think cephalosporins are probably the toughest because while it's easy to remember because they all start with ceph, it's also easy to get them all mixed up. So let me go back to this slide here. This visual should help you as you go down the generations. So moving from first to fourth, you gain gram-negative activity. Lose gram-positive, gain gram-negative. Cefepime is a fourth-generation cephalosporin. The reason that that is important in some of the practice questions, I saw it referencing cefepime. It's an incredibly widely used drug. It has pseudomonal activity. You still have some gram-positive activity, but the hallmark of its use is gram-negative. So it will still cover strep and a little bit of staph, but gram-negative use is kind of its claim to fame. The correct answer to that question is that ceftaroline is the only cephalosporin that covers MRSA. And then cephalosporins as a class have no activity against Enterococcus, so they will not be the drug of choice for that group of bacteria. Okay, so correct answer again here was D. Okay, moving forward into some of our other classes. So we've completed beta-lactams. Excuse me. We're moving into fluoroquinolones. This is another very commonly used class of drug, which has led to this great graphic here that I stole from the Duke Antimicrobial Stewardship Program. They have an incredible program over there, tons of resources, tons of research as well. You can see that fluoroquinolones came into the world in the early 60s. By the late 2000s, early 2010s, if you will, we started seeing black box warnings for a variety of injuries, including tendonitis and tendon rupture. Those are tragic studies that will tug on your heartstrings because they were done in beagle puppies, the worst. Myasthenia gravis, peripheral neuropathy, any sort of CNS side effects, and altered mental status. One of the fluoroquinolones is called ciprofloxacin. They actually call this side effect cipropsychosis. It also will affect your blood sugar, and all of these can also rupture your aorta. So if you've made it through therapy with your tendons and your neurological function intact, you are now also at risk for tears in your aorta. These drugs still offer us oral options against Pseudomonas. There is a time and place for them, is the way that I like to think about it. But the side effects of these drugs are making them much less widely recommended. The next class are the aminoglycosides. These include the drugs amikacin, gentamicin, tobramycin, and plazomicin. The two adverse events for this class that are important are nephrotoxicity, so your poor kidneys take a hit, and also your hearing. I think this meme really represents the worst part when you keep asking people what and you can't hear them and they keep saying it, and eventually you just have to pretend like you heard them and nod either yes or no and hope that you're not saying something offensive, right? So kidneys and hearing are the two things that can be harmed by these medications. These are actually dosed in a patient-specific manner. We will monitor drug levels, and they're almost always used in combination with something else. The exception to this might be a urinary tract infection, but if you have a patient on an aminoglycoside, there is some sort of either resistance or it might be synergy for an endocarditis, so an infection of the heart. So again, toxicities limit our ability to use these, and if you see them, there's likely some sort of resistance in play. Macrolides. Everyone should be really, really familiar with azithromycin or Zpack. These drugs inhibit protein synthesis at the level of the ribosome, and the two most important things are QTc prolongation. So that is something that we will monitor EKGs for so that we don't cause arrhythmias, as well as GI upset. When I was younger, I actually got to take our friend erythromycin over here. It's a horrible medicine. I have never been more ill than when I was taking erythromycin. I had whooping cough, of all things. And yes, I was vaccinated as a child. And then I was placed on erythromycin. I had a little bit older of a physician, and it was the worst stomach cramps and vomiting for 24 hours straight that I've ever experienced. So the friendliest of these medicines is our Zpack. But unfortunately, we also see Z-Packs given out like candy at urgent cares. So this is why we tend to see resistance with azithromycin. It's kind of been a little bit, it's just taken a hit because of the fact that if someone comes in with a cold or a flu, we give them azithromycin and Tamiflu, when really they probably just need Tamiflu. All right, I got a comment that someone else had whooping cough. Girl, power be with you. We're survivors. Okay, sulfonamides are the next drug class. There's only one drug in this class, and it is Bactrim, or sulfamethoxazole and trimethoprim. So it's a combination. One of the perks of this medicine is that it gives us an oral option for MRSA, which is great. Rashes are very common, so very common for folks to not be able to take this because they report rashes. It can also cause more severe dermatologic reactions that can actually be fatal. And we need to monitor potassium, serum creatinine, as well as a CBC. So a little bit more intensive lab monitoring with this. So it gives us an oral option, but for longer courses of therapy, there are some side effects that we have to weigh very carefully. Tetracyclines include tetracycline, which is great. They just didn't even get creative with that class name. They were like, yeah, that was the first one. Let's just name it tetracyclines. Minocycline and doxy. Tigacycline, good question, is a little bit different, so it gets its own family. We'll get to that in a little bit. Doxycycline is bolded because it's the most likely one that you will see. A common adverse event that we used to really worry about was for tooth discoloration in children that were less than 8 years old. Recent data have proven that that is probably not as much of a worry. So if an 8-year-old comes in with Rocky Mountain spotted fever and is really sick, we will still give them doxy. We just like to think twice about if there's an alternative. Pill esophagitis. This is such a real thing. I've got firsthand experience. Before I was in ID, I used to let doctors give me antibiotics all the time. I took doxy for an eye infection, of all things, bless me. And I was in college. I was a freshman in college. I took a tiny swig of water and I laid right down to go to bed. I did not sleep for the rest of the night because the pill esophagitis, it will actually erode your esophagus if you're not careful. So these need to be taken with a full glass of water, and you need to be upright for at least 30 minutes afterward. Nausea and photosensitivity. So if you have people going out in sunlight, they can sunburn very easily. I say when in doubt, doxy it out because doxycycline treats a lot of weird stuff. So some animal exposure bacteria, Q fever, it can be helpful in, as well as your tick-borne illnesses. So sometimes if we've got a really sick individual and they're not responding to anything we give them, we might just give them a little bit of doxy and see if they improve, and that can help clue us in that this might be an odd infection that we're not typically thinking of. Got a question. Is this the medication class that if given to pregnant women, it can discolor the teeth of children as they develop? You are absolutely right on the money. So that goes along with, we don't give this to pregnant women because we did not want to interrupt the active dentition of the children in utero. Again, might be less of a concern, but we can usually use an alternative therapy with the exception of tick-borne illnesses to avoid doxy in kids less than 8 and pregnant women. All right, I would be remiss to do an entire presentation on antibiotics and not touch on vancomycin, vitamin V, another part of the welcome package at most emergency departments. This is our workhorse for empiric MRSA coverage in the inpatient setting. Similar to aminoglycosides, this is dosed in a patient-specific manner. So a vancomycin consult usually means pharmacy is going to take care of dosing. I could do a whole other hour on vancomycin dosing, but you don't need to know that for your life. So just know that pharmacy will take care of it. It can be harsh on the kidneys. So just like aminoglycosides can be tough on kidneys, which is why we will monitor levels for this particular drug. Something called red man syndrome is an adverse reaction that happens when you infuse vancomycin too quickly. It is not an allergy, but people do not like it. You feel very flushed and a little bit panicked. And so it is a reason that we will infuse this drug a little bit more slowly, so over a couple of hours. Dalbavancin and iritavancin sort of represent longer acting vancomycin, if you think of them that way. They are newer drugs in our arsenal, and we're frankly not necessarily always sure about where to put them, where to use them. But right now, I think a good area that we could use these is to avoid admission to the hospital. for patients who have skin infections, superficial skin infections. You can give 1 or 2 doses of these depending on the clinical scenario and depending on the drug, and they do not need to be admitted for continuous IV treatment. Yes, question about Vanc from Luz.
So is vancomycin the one that it's important for it to be under the area under the curve rather than the Cmax?
Yes, so vancomycin, she was asking about PK/PD parameter of vancomycin. Vancomycin is measured by area under the curve. It's sort of the hallmark drug for that PK/PD parameter, which is why when pharmacy's dosing it, we can play with dose, or we can play with how frequently we give it, because we just want that area under the curve to be large. Good question. All right, these are some miscellaneous drugs. I could have given them all their own slide, but I did not want to have you guys here until the end of time. Linezolid is another option for gram-positive infections. So this is an oral option for MRSA. Also has activity against vanc-resistant bugs. So vancomycin-resistant enterococcus. This is one of our agents that we can use. It is static, however, so its use in bloodstream infections is very limited. So if you remember, static drugs, you need more drug and you need a little bit more help from the immune system of the patient for them to work. For drugs for infections rather, like endocarditis, bloodstream infections, etc., we typically want to use cidal agents. Linezolid is also very harsh on platelets, so we have to monitor that very carefully. If they get too low, our patients are at risk of bleeding, so that's very serious. And it is also a weak version of an older class of antidepressants called monoamine oxidase inhibitors. So any patients on drugs that interact with your serotonin, it has to be monitored very closely. Daptomycin is another gram-positive workhorse, kind of a second-line agent behind vancomycin. It is cidal, so if you had an isolate that was vanc-resistant that was in the blood, we would typically use daptomycin. You have to monitor something called CPK, so that can be, it can cause muscle pain if that builds up too much in your blood. It can also cause discolorations in your urine. And we have to monitor patients very closely if they're using statins. So things like Lipitor, Crestor, those types of drugs, we will actually discontinue temporarily while patients getting vancomycin, or daptomycin, sorry. All the mycins. Another option, clindamycin. This is another static drug. It has good anaerobic activity, but the mainstay of therapy is it will be used for gram-positives. Another oral option for MRSA. So our oral options for MRSA so far are Clinda, Linezolid, Bactrim, and Doxy. Clindamycin, though, can be very hard to tolerate with regular antibiotic-associated diarrhea, and it is also one of our high-risk agents for C. diff. So the patients don't always enjoy high doses of Clinda for a long time. Some more miscellaneous drugs. Flagyl or metronidazole is an anaerobic drug. Mostly gram-negative anaerobes, but some gram-positive anaerobes as well. The way that they helped us remember that in pharmacy school was Clinda was good for anaerobes above the belt, so things that live in your mouth, and metronidazole was better for things that live below the belt, so belly and below metronidazole, just because gram-negative organisms typically predominate there. It can cause a metallic taste as well as nausea and vomiting, so I don't think it is the most wonderful drug to tolerate. It used to be part of therapy for C. diff, but we would now only use it in combination with oral vancomycin. So again, used to be a first-line agent for treatment of C. diff, and that got removed in favor of oral vancomycin and fidaxomicin. Nitrofurantoin, I really oversimplified this drug here, but UTIs are really the only time that we should be seeing this. If you are on it for a very long time, you can experience pulmonary toxicity. Not recommended in elderly people. Synarcid is a horrible drug. It is a combination of quinupristin and dalfapristin. And if you're ever seeing a patient on it, That's probably an interesting case, so feel free to call me, but refer to a pharmacist and an ID attending. Patients feel horrible taking this, and thankfully, because of how awful it is to tolerate, we now have better options in the setting of resistance, so we can avoid Synercid as much as possible. Yes, so Luz just asked, is this the one that can only be administered via central line? Yes, it's also harsh on the veins, so it has just another obstacle in the sense that you would want a central line for your patient. All around, just a really bad drug. Speaking of more bad drugs that should only be used in certain scenarios, Glial Cycling, so Tigacycline, it sounds like it should be a tetracycline. It's a little different. This is a last line option, mostly due to the side effect that this emoji should explain. I didn't know until I Googled this emoji that the vomit had so much detail in it, but your patients, regardless, will have profuse nausea and vomiting. We've had adult patients beg us to stop giving them this med because it was causing so much vomiting. It also demonstrated increased mortality in studies involving pneumonia and bloodstream infections. So again, if you are unleashing the tiger, as people will say, this should be last line. Continuing with our theme of antibiotics that are just the worst. If there are any Parks and Recs fans out here, you will understand this GIF/GIF, however you pronounce that, a lot better than the rest of you, but they are the worst. That's all you need to remember. Really, really hard on kidneys, and they can also cause neurotoxicity. Because they are so toxic, so hard to tolerate, they should only be used for multi-drug resistant organisms, if at all. The more we study these in multi-drug resistant situations, the more we realize that patients who receive these drugs do not perform well. So we like to avoid them when possible. Couple of new kids on the block that I wanted to make y'all aware of. Something called Vabomere just got approved, which is essentially another concept of that addition of a beta-lactamase inhibitor to a drug that's already on the market. Recarbrio is the same thing. Imipenem, meropenem, already available. We added Relabactam and Vaborbactam, which are just more beta-lactamase inhibitors to try and overcome those multi-drug resistant gram-negative organisms. Lafamulin is also a new medication, and this was just recently approved for community-acquired pneumonia. I doubt these would be on an exam, and I doubt that they will be used very commonly for the next few years. These are kind of, we don't quite know what to do with them yet because they are so new, but just wanted to make y'all aware in case one day you're like, Vabomere, I feel like I remember that one girl saying something about that. All right, some review questions. Which of the following does not represent an oral option for the treatment of MRSA skin infections? Okay, so actually, all right, we've got more answers coming in. I love this. Okay, this is good. So actually, all of these medicines represent oral options. This sulfamethoxazole trimethoprim brand name is Bactrim. So on the slide talking about Bactrim, that was actually one of its only perks, and then we talked about adverse events. So all of these represent oral antibiotics that have activity against MRSA, so could be used for skin infections for that reason. All right, you are working with stewardship programs, so you're my new work bestie, and we are working to educate providers which of the following things would be accurate. Metronidazole is an effective choice for MRSA infections. I timed that one really well, right? We just went over oral antibiotics for MRSA. We should consistently use broad spectrum antibiotics regardless of susceptibility. Don't choose B. It's always necessary to maintain antimicrobial concentrations in the body above the MIC. Or D, cefepime is only useful for gram-negative infections. So this one's actually one from the material that Luz forwarded me. Okay, so I'm seeing, I think we're between C and D. So C is actually the correct answer. While cefepime is, its hallmark use is its gram-negative activity. So I love those of you that put D because you're on the right path, absolutely. But this is a tricky question, and this was in the material, so this is where I was impressed. I was like, okay, they're going to know their stuff about antibiotics to take this test. Cefepime is not only useful for gram-negative, we can also use it for some staph, some strep, which are gram-positives, but C is actually true. So if we go back, looky here, to that PK/PD slide, you see that area under the curve and Cmax, both of these sets of drugs, it can fall below the MIC, and that's okay because we're going to then give another dose and give another hill of drug, if you will. Time above the MIC antibiotics are really the only ones that want to stay above that minimum inhibitory concentration all the time. So it is not always necessary to keep a concentration of a drug above the MIC, but for the majority of the dosing interval, we would like it to be above that. All right, which of the following is not a beta-lactam?
I know this one.
All right, Luz feels confident. All right, I think I'm seeing majority, it's between B and D. So beta-lactams, the four things that make up a beta-lactam, you have penicillins, cephalosporins, carbapenems, and aztreonam. Yes, gentamicin is an aminoglycoside, so B is the correct answer. Amoxicillin is a penicillin. Ceftriaxone, the CEF at the beginning, clues you in that it's a cephalosporin. And then ertapenem, the last name here, tells you that that's a carbapenem. So gentamicin is an aminoglycoside. Again, beta-lactams are penicillins, cephalosporins, carbapenems, aztreonam. Okay, super briefly touching on antibiograms and kind of how I use them in practice, just because I saw that the chapter that Luz had me sort of base this off of, it referenced antibiograms a little bit. These are primarily compiled by the lab, but pharmacists can help. When I helped with the one with residency, we essentially just helped it become a document that was useful clinically. These compile all of the isolates within the past year or whatever the time frame may be, and they describe the susceptibility patterns for the local environment. You must have a certain number of isolates of each bacteria for them to be included, and this is useful only for empiric selection. So this helps us up front when we think a patient might have a certain bacteria. When we get individual patient results back, we use those, which makes sense because that's the patient's body telling us what bacteria they have, right? For an example, this is Vanderbilt's antibiogram from back in 2016, a little bit not relevant anymore. If I tell you your patient has E. coli in the urine, we don't have susceptibilities yet, we're still waiting. Which of the following antibiotics represent the best empiric option? So we just know it's E. coli, we don't know what it's susceptible to, and we have to pick a drug. I got this call all the time, and nothing terrified me more as a new baby pharmacist with my brand new shiny license than picking out a drug. All right, I'm already seeing some speedy answers come in. Nice work, nice work. I'm going to walk through this as y'all continue to answer. I think D is looking like the most popular option. Let's see what we think. I like to walk through these one by one. So let's look at cefazolin first. The way that you would read this is cefazolin. This particular antibiogram is separated out by non-urine and urine, which is common for E. coli to be reported this way. If we look at cefazolin, you see that urine isn't even reported. So that seems risky, right? We don't report that. Next is ampicillin. So let's come over here to ampicillin. Ugh, the fact that it's in red already has me feeling nervous, right? So this means that of all E. coli non-urine isolates, only 40% were susceptible to ampicillin in 2016. In urine, only 48%. That's worse than flipping a coin to see if your patient's going to live or not. Cipro, similar numbers, kind of a coin flip for non-urine, a little bit better than a coin flip for urine isolates. And then we have our answer, which is D, which is Zosyn or piperacillin tazobactam, where we can be 95% confident in the urine that out of all the urine isolates in 2016, 95% of them were susceptible to Zosyn. So that makes us feel really confident. You'll see that these are color coded like a stoplight. We had green, yellow, and red at Vanderbilt. Each facility does their antibiogram a little differently. But if you have a sick patient and you have to decide on empiric therapy, 85% and above is reliable. With certain organisms like Pseudomonas, you may just have to work with what you have, and your best agent may only have 80% activity on your antibiogram, and that's okay. This is empiric. You see that ertapenem and meropenem both have 100%, so you may be thinking, why didn't she list those? We want to reserve those for the patients that truly need them, so we want to save those for resistant scenarios. And since only 5% of isolates were resistant to pip/tazo, that would be a perfectly fine option for empiric therapy for E. coli. All right, resistance. Why do we care about this? Briefly, people die, which is a good enough reason for me. It's also expensive to have resistant bacteria. That's up to $20 billion in annual expenditures, and we think that is accounted for, or is made up by rather, 47 million unnecessary prescriptions per year at least. That makes a small part of my heart die every time I think about 47 million antibiotic prescriptions for patients that didn't need them. So that's what my job is trying to avoid that. Mechanisms of resistance. This diagram, I am not a visual person as much as I am a written language person. So I've got this slide for those of you who like visuals, and the next slide is for those of you who like words. So hang on if you're like me. There are 4 different major categories of resistance. You can have efflux pumps. That is the bacteria vomiting the antibiotic out of the cell. Okay. You can have enzymes. You can see enzymes may be represented beta-lactamases. Anything that ends in ACE is an enzyme. So beta-lactamases and antibiotic modifying enzymes. Both of those are accounted for by enzymes that will either destroy, inactivate, or physically change the antibiotic to make it ineffective. You'll see things like loss of porins or mutations in structure. All of those can be summarized to say that if the drug cannot get to the target, so altered target site, it cannot be effective. So to summarize that sort of in 4 different categories, you can have enzymes causing antimicrobial resistance, efflux pumps, which is the bacteria vomiting the antibiotics out, target site alteration. It can fool the antibiotic. It can change, so it can't bind. If it can't bind, it can't kill. And you can have decreased uptake. So we're just not uptaking it. They can reverse channels. Bacteria are so creative. It's very annoying, but it also gives me a job. This can be a whole lecture in and of itself. What I want to point out is that after all the drugs that we went through today, and there are way more that I haven't even gone through, we still have entire classes of bacteria that we have no good options for. And that's not an exaggeration. It literally means we will combine antibiotics to try and get some sort of synergy or the antibiotics working together. But at the end of the day, I have nothing good to offer those patients. We do the best we can with what we have. We try to get source control for those patients. But that is where you see the premature deaths from infections. And it's incredibly unfortunate. So I showed you some new drugs. Gram-negative resistance is really where we're seeing a lot of the new drugs come out on the market right now. But gram-positives, again, MRSA, vancomycin-resistant enterococcus, those should not be underestimated in terms of the severity of a threat that they pose to our patients. Okay, you're an IP now. You passed your test. You're doing wonderful. You are thriving. You have been asked to join the stewardship team at your facility because we love you guys and you're awesome. Effective strategies to curb resistance include all of the following except formulary restriction, which means reserving some antibiotics that only ID can prescribe, administering antibiotics with overlapping activity, automatic stop dates, which means pneumonia should be treated for 7 days, I'm putting in an automatic stop that after 7 days it'll be over, or acting on rapid diagnostic results. All right, I think we're between B and D. So B is actually the answer. When we give antibiotics with overlapping activity, which means that both antibiotics cover some of the same things, that can actually perpetuate resistance. So it is a human instinct, I think, to want to say, one's good, but more feels better. And that's unfortunately with bacteria not always the case. So we try to eliminate overlapping activity where we can. There's a couple of exceptions to that, but by and large, overlapping activity is something that I screen for every day. I just got a message. We have a 6-year-old child with community-acquired MRSA in our community. Absolutely. Resistance is a scary thing, and it does not discriminate. I took care of kids less than 1 year old who had unfortunately been in the hospital for other reasons and had really bad resistance, and they were only literally barely out of the neonatal period. So resistance is irritating, to say the least. All right, I have about 4 minutes left to summarize my job and everything it stands for. This is the definition taken from the book, but the way that I like to break this down is antimicrobial stewardship is an active process. The core in the documents that sort of describe what stewardship is recommend an ID-trained pharmacist and an ID-trained physician team up to lead a team. That does not mean that we are the only two people doing stewardship. Stewardship is, I like to say, everybody's a steward, but people think that's cheesy, and that's fine, but it's true. Stewardship involves literally every single human being in the hospital, the lab, nurses, everyone washing their hands is a way to practice stewardship, because if we're not transmitting infections, everyone is happier. The way I like to define stewardship from my perspective as a pharmacist is right drug, dose, duration, route, and I want to optimize my patient's outcomes. I call myself the Sherlock Holmes of medicine because I'm always thinking, is there a better way we can do this? Is there a clue I'm missing? Is something else out there? CMS has now required, hallelujah, at the end of September, stewardship programs for hospitals. We've had them for nursing facilities, but now CMS is upping the game with stewardship in hospitals, which is so awesome. The pharmacists can get training a couple of different ways. I did a PGY2 residency where I spent the whole year specializing in infectious diseases. Other folks have just been doing this for years and years and years, and they're awesome. And then there's also certificates that you can pursue through organizations like SHEA and IDSA. We are not the antibiotic police. We're still really fun. Hopefully this webinar has encouraged you that I'm still fun. We're not just running around telling people, no, you can't use that. No, you can't use that. We're also not the primary care team, and we're not ID consult. So sometimes we talk to the ID consult service and say, hey, can we narrow therapy? Can we increase therapy? Did you see this culture result, etc.? We work in conjunction with these people. This is a hypothetical scenario that y'all can read when I send out slides, but just kind of walks you through some questions that I ask myself. And these are the various activities. This is not an inclusive list, but sort of how I can help IP. So I help with formulary review, and I review antimicrobials. I review all the restricted antimicrobials. I encourage stop dates. I receive pages every time there's a positive blood culture, and I relay that information to the physicians with recommendations. I educate. I do stuff like this. I love doing stuff like this. I will counsel patients who are going home on antibiotics, et cetera, et cetera, et cetera. We're really lucky at Celebration to have awesome IP colleagues. I'm biased because I work here and Luz is sitting right here, but I would say it even if she wasn't sitting right here. We actually attend stewardship rounds weekly with our physician. We can work to review cases. Hey, did you see patient in blah, blah, blah room? How's this? Just wanted to make you aware. And that goes both ways. And then optimizing time to treatment. When we're working as a team, it betters patient care. So I think that is really awesome. And she can also tell me who's not washing their hands, and I can spy on them when I'm up on the units as well. Had a question about how to advocate including nurses in antimicrobial stewardship. Great question. This is actually a very trendy topic in ID right now. Nurses are at the patient's bedside, so they arguably know the most about what's going on with the patient because they spend the most direct face-to-face contact time with them. They will work to ensure stop dates, are being done. Hey, doc, did you see the patient's blood culture came back as blah, blah, blah? They are an invaluable resource in terms of keeping everyone aware of side effects and drug levels and all sorts of other things. So because they are truly the front line of patient care, they can be used in so many ways to help stewardship. All right. And just a little personal story. Luz, no offense to you at all, but this is my sister. She's getting her master's in public health and epi right now. So I want all of y'all to do so well. I have a personal stake in you guys doing well and going out and passing these exams. So this is my sister, future IP colleague, and that'll be pretty cool. I always say the love of infectious diseases is contagious. So it's gotten through most of my family. All right. Any other questions? I will certainly send the link. Well, it's probably not me. It's probably going to be Luz, and slides and all that other stuff. And I'm happy to send along my email as well if you guys have questions moving forward. You guys are so nice. You're so welcome. Thanks for saying thank you. All right.
Wow. Hey guys, it's me. I'm back. This was really, really fantastic. How many of you want to hear from Jillian again? Because I think that she could have done some really good work with explaining some of that carbapenem resistance. So do you guys want to hear from her again? Yes, please. Absolutely. Okay, good. Jillian, you're the crowd loves you. The people loves you. Okay, so this is this is perfect. Well, I'm really glad that you guys enjoyed the presentation. I think it was a great overview. This is definitely an area where I am not an expert, so it's really great to have Jillian here to share all of her expertise with us. And be on the lookout for the recording. She's going to send me a PDF of her PowerPoint. So that's pretty much it for today, guys. Thank you so much for listening in, and I will see y'all in November. When is the next one? Well, we don't know yet, but as soon as we know, I will let you guys know. Okay, bye, guys.